Hi guys, welcome back. This is Dr. Marva and today we shall be talking about pleural effusion. You are familiar with the fact that the normal amount of fluid in our pleural space is about 5 to 15 ml. They have asked in the exam what is the rate of production of the pleural fluid in a normal individual. So the parietal pleura is responsible for production of this pleural fluid, which is obviously for lubrication purposes, and the answer should be given as 0.01 ml per kg per hour. That's the rate of synthesis of the pleural fluid in a normal individual. Obviously, some of this would be reabsorbed by the lymphatics, but ultimately the amount of fluid would be 5 to 15 ml. Now, once you remember that, the standard question that they're asking is that what is the minimal amount of fluid for clinical detection? So just like in ascites, you remember that it is 100 ml on clinical detection with the help of a puddle sign. The minimal fluid which is present in the pleural cavity for clinical detection should be remembered as 300 ml. Less than 300 ml because the fluid would basically settle down in the claustrophrenic angles. It is a little difficult to detect, or in fact most of the time we will miss out a pleural effusion if it is clinically amount is less than 300 ml. Now when it comes to minimal pleural effusion, because there are standard questions, so I'll just cater to them first. One they'll always ask you will be that what is the best investigation for a minimal pleural effusion. Now, if the question is like best test for minimal pleural effusion, your answer would be a CT chest and then obviously a ultrasound chest. The problem is that CT may not be available all the time in our country. So that's why you will see that lots of time the answer would be given as a ultrasound. Comparing the two, then I would say that CT will obviously be having a higher amount of diagnostic accuracy as compared to plain ultrasound chest. Again, ultrasound test is the more of a operator dependent technique, and if you are not going to place the probe properly, there's a possibility that you might miss out the finding. But CT is not dependent on, I would say, the technician, because we are having a proper computerized algorithm. So even if you are very casual, if you scan the films, you will definitely be able to see the marking of the fluid. So the best test for diagnosis of minimal pleural effusion is a CT chest followed by ultrasound chest. Then that old MCQ of X-ray lateral decubitus has become very outdated. I'll put it like this. I mean, nobody is nowadays asking that how much ml of fluid should be present for detection of a pleural effusion by a lateral decubitus position. That is 50 ml, and you know that from radiology classes, and that's a hugely disputed MCQ. Lateral decubitus position, placing the position, then estimating the amount of fluid, which is 50 ml, some books saying 20 ml. So nowadays they've stopped asking all the controversial aspect. They've straight away hitting the nail on the head. They have said, you have done a upright chest X-ray in a patient as you standard do in a hospital, a upright chest X-ray PA view. Then obviously when you do a PA view, you can do a lateral. So nowadays what they're asking is like you are doing a chest X-ray of a patient in an upright position, and one they're asking that if you are gonna do a lateral view versus a PA view, then how much fluid should be present to be detected on a lateral view in a chest X-ray. Then it is 100 ml. But when it comes to a chest X-ray upright PA view, that is a frontal view, like the standard image that you can see currently on the monitor of yours, then the frontal view would be at least 200 ml. Then there was chest X-ray upright frontal view. How much fluid should be present that you will be having a obliteration of the hemidiaphragm? Then the amount of fluid should be in excess of 500 ml. Now, since I've said multiple mathematical values here, let's quickly revise as follows. The best test for detection is obviously a CT chest. 100 ml is for a lateral view, not lateral decubitus, I'm saying, because that's 50 ml and that's hugely disputed. So I'll not get into that controversy. And there is no point, sir. Let's be frank. I mean, hardly any controversial questions are asked. It's straightforward facts that they're asking now. When it comes to frontal view, it would be 200 ml. Clinical detection is 300 ml, and for obliteration of heavy diaphragm it's 500. So it's 100, 200, 300, 500, and I hope I have been able to make you remember this. One of the very classical features that you will always be noticing in a pleural effusion would be obliteration of the costophrenic angle, obviously first and then the cardiophrenic angle, but the CP angle is the one which will obviously become obliterated, and there might even be a development of a mediastinal shift if there is a massive pleural effusion, which we will discuss in our subsequent slide. But I would just like to highlight the fact that if they give you an image like this, where you can notice a very characteristic obliteration of the pleural space, then it's a very characteristic feature of pleural effusion. And you can obviously notice the meniscus sign present here, which I have highlighted. So one of the easy ways to identify pleural effusion would always to notice the blunting of the costa of running angle and presence of a meniscus sign, which is very standard, very straightforward. Now, in the exam, what they did was they have given the situations of bilateral pleural effusions, as you can see, very easily identifiable meniscus sign in both the cases and a bilateral pleural effusion present in a patient. And well, this is obviously a AIMS MCQ where you can notice that the upper border of normally, like we have a meniscus sign, so it would be having this curvature with the levels higher in the area of the axilla. The fluid tends to accumulate higher in the axillary area as compared to the standard one. But you can notice in this case, there is a straight border. So this is definitely not a pleural effusion. This would be answered by you as hydropneumothorax. So just get the facts right. If you are having a whiteness in a chest x-ray which is causing obliteration of the CP angle, there is a CP angle blunting that is noticed in both the x-rays. But if you are noticing a meniscus sign, it is obviously going to be a feature of pleural effusion. If there's no meniscus sign with a straight border, that's a combination of the two. That would be hydropneumothorax. So that tells you the fact that there would be some air also present in this particular case, which would obviously rise, and the fluid will obviously settle at the bottom. Remember, lungs of our body are lighter than fluid, so fluid always settles at the bottom. Lung keeps on floating, and therefore you are noticing this peculiar image. Now I'll just move out and show you a CT chest, which is showing a substantial amount of fluid accumulation compressing the lung parenchyma of the patient. So as I said, CT is obviously very accurate and it's technology driven as compared to ultrasound, which might be operator driven also. Now, once we have looked at these images which I mentioned and are easy to pick up, let's just work out the etiology also. As far as the etiology of pleural effusion is concerned, there are two varieties. One is called as the transudative variety and the exudative variety. To understand the hydrostatic transudative variety, there are two varieties of pleural effusion, transudative and the exudative variety. When it comes to the transudative variety of pleural effusion, on one side you can obviously see the hydrostatic pressure head, and on the other side you can see the oncotic pressure, and the balance between the two will obviously determine the amount of pleural fluid present in the pleural space. You can see that the hydrostatic pressure head will drive the fluid into the pleural space, and the oncotic pressure will be then responsible for reabsorption of the fluid back into the intravascular compartment. Now, if there is any condition that's going to upgrade the hydrostatic pressure, or there is any condition that is going to downgrade the oncotic pressure, you are going to have a pleural fluid in excess. You can see from the figure, if hydrostatic pressure will increase, there is going to be more fluid accumulating in the pleural space of the patient. On the other hand, if the oncotic pressure will reduce, then the fluid will not be able to come back into the intravascular compartment of the patient. Conditions which can contribute to increase in hydrostatic pressure could be like congestive heart failure. It could be constrictive pericarditis. So what I'm basically saying is that most of the time he will talk about valvular lesions, or he can talk about congestive heart failure. And in fact, I can put it like this, that overall, if he says what happens to be the most common cause for a transudative pleural effusion, then for the transudative variety of pleural effusion, overall the most common cause responsible is heart failure or valvular heart disease. In contrast, when it comes to reduction of oncotic pressure is directly related to the value of albumin. So if albumin in the blood would be lesser, like for example, you can take up cirrhosis, you can take up a scenario of nephrotic syndrome, or you can take up protein losing enteropathy. Whenever you are gonna be having a hypoalbuminemia due to any of the conditions that I have mentioned here before you, then you are gonna have a transudative pleural effusion. Remember that transudative pleural effusion will always be bilateral. This is because the pressure is equally distributed between the left and the right side. So in fact, sometimes in the MCQ, he might not say the word transudative pleural effusion, but he might say what is the leading cause of bilateral pleural effusion. Then the answer should obviously be given as heart failure. Now, when you compare the transudative variety of pleural effusion with the exudative variety, Exudative variety can be unilateral, or the exudative variety can be sometimes even bilateral. We really can't predict it. So let's talk about causes of exudative pleural effusion, where the leading causes are parapneumonic effusion. I mean, don't straight away in the MCQ jump the gun and start talking about tuberculosis. Yes, TB is an important cause of exudative pleural effusion. But prior to that, one of the important causes that is to be remembered is parapneumonic effusion, which could be a combination of two things, that is a pleural effusion as well as obviously a pneumonia. And apart from this, you need to remember malignancy, which is one of the highly important causes for malignant pleural effusion. And they always ask you, what is the leading cause of a malignant pleural effusion? Remember, the leading cause for this would be adenocarcinoma of the lung. And why am I saying adenocarcinoma of the lung? Well, the reason for that is very straightforward. Adenocarcinoma of the lung is peripherally located. So it will keep on causing irritation of the pleural surface, resulting in an exudative pleural effusion. Then MCQ wise, after tuberculosis, rheumatoid pleural effusion is usually asked, and was asked even in the May 2019 AIMS exam, which I'll talk about. And then they ask you regarding Meek syndrome. So I'm focusing on the core issues which are going to be asked for the exudative variety. Remember the fact that the exudative variety can either be unilateral or it can be bilateral. We really cannot be sure. And if you do a thoracocentesis, you will notice the fact that the fluid clots on standing when it comes to an exudate, whereas in transudate, obviously it would be just like water, so it will be transparent like water and would never clot. Now, we do have Light's criteria by which we can differentiate a transudate versus an exudate, but when you take out the fluid in a syringe, you can obviously notice the fact that the fluid clots on standing in an exudative pleural effusion. Now, before we go into what is the specifics of these, I would just like to mention regarding a common question which has been asked with respect to cytothoracocentesis. Thoracocentesis, guys, is obviously to be always done ultrasound guided. There was a case in Mumbai where a doctor's license was cancelled since he had done a thoracocentesis without ultrasound, and the patient had developed a pleural effusion, and they said that there was not a proper protocol that was adhered to. So I would suggest you to avoid doing a blind thoracocentesis. Now, since this is a academic class, they can definitely ask you that you would do a thoracocentesis from which side and what is the indication for doing a thoracocentesis. Then I can say that the indication, one of them for performing a thoracocentesis in a patient would be when there is a substantial amount of fluid present in the pleural space, which I'll just highlight like this. So what I've done in this case is that I have highlighted the pleural space. Yeah, I have shown the pleural fluid in this case, as you can see. And this is obviously the normal lung border. This is the normal lung border that I have shown here before you. So what I'm saying is that radiologically speaking, if there is a distance of more than 1 centimeter, as like here I've shown more than 1 centimeter, obviously, if there is a more than distance of more than 1 centimeter between the pleural surface and the lung border, then this on an X-ray, if it is present, then this is an indication for doing a thoracocentesis. I'm putting the word blind to say the fact that because of the fact that lots of time in a government hospital facilities are not available, ultrasound radiologist may not be available, so you might be doing a thoracocentesis in a patient without obviously a sonographic guidance, which is ideally not recommended, because if it's a loculated effusion, God help this guy, because you might be hitting an area where the fluid may not be present, and therefore you may not be able to aspirate it out, or because the loculations might ensure very limited amount coming out. So it's a good idea to do it ultrasound guided. If not available, then blind thoracocentesis. Blind is the unofficial word that I'm putting here. Do not take it in the literal sense, right? This thoracocentesis guidelines are when there is more than 1 centimeter of fluid separating the lung border from the pleural surface. I repeat, 1 centimeter of distance between the lung border and the pleural surface, then you would be doing a thoracocentesis in a patient. But ideally it should obviously be ultrasound guided. And well, what would be the preferred site? The answer would be given as 7th intercostal space. You would make the patient sit like this, cross his arms, make him lean onto the table. This is going to spread out the scapula a bit, and then poke him behind, that is at the scapular line. So 7th intercostal space, scapular line is the preferred site for thoracocentesis. Here I've seen a lot of guys casually answering mid-axillary line for ultrasound guided, or even let me say a blind thoracocentesis, fifth intercostal space mid axillary line. My only point is, guys, if you are hitting it on the fifth intercostal space mid axillary line, you can definitely injure either the diaphragm or even the liver on the right hand side. So it's always recommended to do it by standing behind the patient. In fact, I can just show you an image for this so that it becomes a little more comfortable for you. You can see the fact that the patient here is sitting upright and is leaning on the table, so you can see the fluid will obviously settle down, and then obviously you can do a thoracocentesis from the back on the scapular line on the patient. If you are going to do it on the mid axillary line, the chances of damage are substantially high. As you can see in the corresponding image, you can either cause a pneumothorax. Now this is definitely a medical complication, medical legal complication, from the perspective that patient can sue you for this. So you obviously have to go in for a ultrasound guided procedure, and you can see the inferior diaphragm, the needle that is actually traumatizing the diaphragm and is hitting the liver surface also. So it's recommended you do it ultrasound guided, as I have highlighted 2-3 times. And let me put it like this: if there's an unfortunate complication like pneumothorax developing in a patient, your HOD is not going to come to save you. You are on your own, so always adhere to the protocols, always adhere to your notes, and always write a requisition for ultrasound guided process was turned down. This would definitely save you, because then the onus will turn out to be on those people who are supposed to provide you with facilities. Considering the anti-doctor atmosphere, I just thought I should say this fact, because I had a very unfortunate experience of discussing with the guy who actually his license was hampered because of simple the fact that he did everything right, but because the backup of the government and backup of obviously his department was not there, so he had to suffer because of that. Coming to the main agenda, when it comes to pleural effusions of the various varieties like I have mentioned here, so we'll talk about each one of them one by one. The first one that I'll talk about would be a pleural effusion related to malignancy. This would obviously be a massive pleural effusion, so you can imagine this to be a lung cancer. This is a peripherally located lung cancer, and what it will be doing will be that it will be causing a continuous irritation of the pleural surface of the patient, and therefore my patient is going to develop a massive pleural effusion. If they ask you that what is the leading cause of development of malignant pleural effusion versus a malignant ascites, then you should be spot on with the answers. When it comes to malignant ascites in a patient, the leading cause would be ovarian cancer. But if they ask you that what is the leading cause of a malignant pleural effusion, your answer would be lung cancer, that is adenocarcinoma of the lung. You can see in the figure that the peripherally located lung cancer will cause a continuous irritation, resulting in a massive pleural effusion developing in the patient. Because of this massive pleural effusion in a patient, there would be definitely symptoms developing in the patient which are in the form of trypopnea. What I mean by trypopnea is that the dyspnea of the patient will tremendously increase on lateral decubitus position. You can understand whenever he will turn to one side, the fluid will literally crush the lung because of the effect of gravity. If this part is relatively higher, then you can understand the fluid will be totally crushing the lung parenchyma. So dyspnea would be increasing in lateral decubitus position. Normally we study about orthopnea or we study regarding platypnea, but in this case we are studying regarding trypopnea. Therefore, for management of this patient, I'll obviously do a thoracocentesis as I explained to you. The good news is that with help of thoracocentesis in this individual, we will definitely be able to remove the fluid, but the problem is the fluid in this case will come back. I have performed a diagnostic thoracocentesis in this individual. I've sent it to the laboratory where I will be able to evaluate it is an exudate based on Light's criteria. What I mean by Light's criteria is that you would be checking for the pleural fluid contents. That is, you would be checking for the proteins in the pleural fluid. You would be checking for the LDH values in the pleural fluid. So if you read the fact that the pleural fluid protein is more than 0.5 times the value of the serum protein, then this would definitely indicate that this is a exudate and malignancy is an exudate. Pleural fluid LDH is more than 0.6 times the value of the serum LDH, or instead of writing like this, he might write pleural fluid LDH more than 0.6 only, 2 by 3 times the upper reference limit of serum LDH in a patient, then in those patients, we have to obviously consider this as important parameters of Light's criteria. Ideally, 1 out of 3 is sufficient for diagnosis of an exudate, but he says the fact that there are 25% cases where Light's criteria might actually misdiagnose a pleural effusion. So we are not 100% sure, and we obviously need to do more workup of the patient in the form of checking the pleural fluid sugar, because when it comes to malignancy, the pleural fluid sugar will also be reduced, and you will also notice that there would be malignant cells that can be seen on cytology. Like you can take the pleural fluid, centrifuge it, and in the sediment you can see the cancer cells. So pleural fluid sugar is definitely not a component of the Light's criteria, but when it comes to evaluating a malignant pleural effusion, he says the fact that apart from Light's criteria, you must simultaneously evaluate for pleural fluid sugar, and obviously cytology should be done where we will centrifuge the pleural fluid, and then a microscopic examination for cancer cells can be done to identify a malignant pleural effusion. Now is the point that once we have identified it's a malignant effusion, what are we going to do for it? So I'll obviously put in a chest tube in this guy and remove the fluid. If they ask you that what is the maximum amount of fluid, why I said a chest tube is because if I am gonna remove the fluid in this particular case, it will reaccumulate again, and once it will reaccumulate again the patient will come back to us. So we need to do a procedure in this guy that is known as pleurodesis, where we will inject a sclerosing agent into the pleural space so that there is a obliteration of the pleural cavity and the fluid is not going to reaccumulate. If they say what is the maximum amount of fluid that can be removed, maximum fluid removed per episode of thoracocentesis, then the amount of fluid according to the British Thoracic Guidelines is maximum 1500 ml. Though in clinical practice we usually avoid taking out more than 1 liter, but I can say the fact that according to the BTS guidelines, the British Thoracic Society guidelines, that's what I'm quoting, the maximum amount of fluid that can be removed per procedure is something in the range of 1500 ml. And well, why is it that you're not removing fluid in excess of that? That is because of the chances of development of re-expansion pulmonary edema. Whenever you are removing the fluid in a case of, let me say, a lung cancer where a massive pleural effusion is present, if the patient starts developing hiccups or if the patient starts developing chest pain, then you might have to prematurely terminate the procedure also, because that's because the phrenic nerve is getting irritated. So do not wait for 1500 ml to be evacuated. Only if there is, I said, chest pain, hiccups, persistent ones present in a patient, you might have to terminate the procedure early. And most of the time you will notice that as you remove this fluid, as you create more space for the lung, because lung, I said, is floating on the fluid and it's compressed by the fluid which is present. So it's a good idea so that once you remove the fluid, I mean, the lung would get opportunity to re-expand, and therefore the difficulty in breathing of this patient will be minimized or will definitely be treated. Now, once you remove the fluid, there's a problem of reaccumulation of fluid. So once you remove this fluid, let me say in 2 sittings, or let me say you took out 1000 ml today and 1000 ml tomorrow, or like 1000 ml today, 1500 ml tomorrow, whatever be the amount of fluid that has been removed in multiple sittings, then you will be injecting doxycycline into the pleural space. The advantage of injecting doxycycline into the pleural space via inserting a chest tube is to ensure a proper distribution of doxycycline into the pleural cavity, and this would be advantageous because this is gonna cause development of adhesions between the various layers of the pleura. Obviously, I am causing my patient to end up with development of restrictive lung disease, extra parenchymal restrictive, but this is the max I can do for my patient. If I deliberately cause adhesions to develop, as I've shown here, if I deliberately cause adhesions to develop between the layers of the pleura, then the chances of reaccumulation of fluid are definitely negated, and we can handle this patient of malignant pleural effusion, at least from the pleural effusion perspective, relatively better. So they've asked what is the procedure of choice for management of patients of malignant pleural effusion. The answer would be given as pleurodesis. Maximum amount of fluid removed per sweating acid is less than 1500 ml, and the risk is obviously a re-expansion pulmonary edema in the patient. A related MCQ to be remembered here is orthopnea, which is characterized by breathlessness that will increase in supine position and is a feature that is seen with heart failure. Also in the cardiology section, I have spoken about platypnea, which is characterized by increase in the breathlessness of the patient in sitting position. The best example for platypnea should be remembered as atrial myxoma. This would be a tumor which would be responsible for tumor plop sound and would be causing platypnea. Another cause to be remembered for platypnea would be hepatopulmonary syndrome. Hepatopulmonary syndrome is a complication of liver cirrhosis in an individual. So these are a couple of causes for the difficulties in breathing that you should definitely be familiar with. Now, once we have remembered malignant pleural effusion, I'll just go back to this list and just put a tick marks here saying the fact that I have mentioned it already. Parapneumonic effusion, guys, can be seen with community acquired pneumonia, like patient had a pneumococcal pneumonia, then there's a pleural effusion which is simultaneously present. The only point I can add is if you fail to diagnose a parapneumonic effusion, things can get really bad, because then you could be having an empyema. And empyema is definitely an indication for putting in a chest tube in the patient in the fifth intercostal space mid-axillary line, because you're having fluid in the pleural space, right? That would definitely contribute to high-grade fever with chills and rigors, and you will have to anyway evacuate the pus in the pleural space. For tubercular pleural effusion and rheumatoid effusion, the aspects to be remembered are like this. When it comes to a tubercular pleural effusion, remember that this is an example of an extrapulmonary TB. I repeat my statement, tubercular pleural effusion is actually classified as an extrapulmonary TB. One of the tests that they'll always ask you, and you would have done MCQs on for this one, is levels of adenosine deaminase in the pleural fluid. And the higher the levels are in the pleural fluid, it indicates that there is definitely a severe amount of inflammatory process going on in the lungs of the patient. Then if he says what is the investigation of choice for tubercular pleural effusion, in those circumstances, if there is investigation of choice asked for a tubercular pleural effusion. However, if he says what is the investigation of choice for tubercular pleural effusion, then your answer would be given as pleural biopsy, on which you would be performing a CBNAT or a gene expert. Remember, CBNAT or gene expert basically mean the same. It is just that gene expert is the one that is given in American textbooks like Harrison, whereas CBNAT is a term that is used by Government of India, that is cartridge based nucleic acid amplification technology. So investigation of choice is not a pleural fluid gene expert. I repeat that it's not pleural fluid gene expert, it is a pleural biopsy gene expert for confirming a diagnosis of a tubercular etiology. And it's not a necessity that every time you might have a very significant pleural effusion, you might just be having a pleuritis. When it comes to rheumatoid pleural effusion in a patient, the highlight of rheumatoid pleural effusion is that it is an exudate. Now, why is it important, or why is it asked, is because you can get easily confused with rheumatic process. Remember, we are talking about rheumatoid. Rheumatoid has inflammatory nodules present. These nodules are usually found in the skin in the extensor distribution. The same inflammatory nodules could be present in the lungs, they could be present in the heart of the patient, and the breakdown of these nodules, the inflammatory nodules undergo a breakdown, and therefore it would result in development of a exudate. So this is definitely gonna satisfy the Light's criteria. And apart from this, there will obviously be a low pleural fluid sugar. Low pleural fluid sugar is obviously present in infection. Low pleural fluid sugar is present in malignancy. And low pleural fluid sugar is obviously present in rheumatoid arthritis associated pleural effusion. So these are three causes that you have to remember for a low pleural fluid sugar in an individual. Then on a microscopic examination of the fluid of this particular individual, cholesterol crystals can be seen. This was a question in the May 2019 AIMS exam. So you need to remember cholesterol crystals in pleural fluid is definitely a feature of a rheumatoid pleural effusion in a patient. Do not confuse with rheumatic, because rheumatic will definitely not cause a pleural effusion. Rheumatic mainly causes a development of a carditis in the patient. Then another aspect to be remembered is Meek syndrome. Why Meek syndrome is asked is because this is obviously associated with the ovarian tumor, that is a fibroma or a thicoma, which is associated with ascites and is associated with right-sided pleural effusion. So most of the time, the question will begin by saying which of the following conditions will be associated with right-sided pleural effusion, and your answer would be given as Meek syndrome. Now the counterpart MCQ of Meek syndrome is left-sided pleural effusion. Left-sided pleural effusion can usually be encountered after surgical aspects. One of them being obviously acute pancreatitis involving the tail of the pancreas, not the head of the body. Remember, I said acute pancreatitis involving the tail of the pancreas is associated with the left-sided effusion. The term that they will use to describe this would be called as sympathetic pleural effusion. This is mainly to highlight the association of a pleural effusion with pancreatitis. Then even in Boyer syndrome, where there is a rupture of the esophagus of the patient, you could be having a left-sided pleural effusion. Left-sided pleural effusion is also seen with esophageal cancer, that is esophageal malignancy. So as I said, most of the time when it comes to right-sided pleural effusion, you will be studying regarding gynecological malignancy. If it is a left-sided effusion, it's going to be the following aspects which are to be remembered. Bilateral pleural effusion, I have already highlighted in the starting of this discussion. Bilateral pleural effusion is going to be heart failure and obviously other causes, but obviously transudative bilateral pleural effusion, heart failure is one of the important ones to be remembered. Then they can ask you regarding hemorrhagic pleural effusion. Hemorrhagic pleural effusion will be having a hematocrit value of about 0.5 times that of the blood. Hemorrhagic pleural effusion can be seen with tuberculosis. Obviously, I'm not writing trauma because that is very obvious, but hemorrhagic pleural effusion can be seen with TB. It can be seen with the lung cancer and even with mesothelioma. In fact, the surprising thing is that mesothelioma, which is associated with asbestosis, can not only be having a pleural plaque calcification, but can be having a hemorrhagic pleural effusion. So I'm writing it vice versa also. Mesothelioma, the MCQ said, which condition will cause pleural plaque calcification? Very straightforward. That is going to be mesothelioma. And then he mentioned regarding bloody pleural effusion present in this case, which is definitely the case. These are a couple of aspects which I want you to remember for pleural effusion topic, especially with respect to the side, I would say, right-sided, left-sided, bilateral effusion, hemorrhagic pleural effusion. Those are some of the domains that they've asked with respect to the various ears. So I have tried to give you explanation for the exudative variety, that is the remaining ones which I have catered here. And once we've done this, we'll just quickly revise the important aspects for pleural effusion. If they ask you that what is the characteristic of a normal pleural fluid, though they'll obviously ask you abnormal also. If they ask you what is normal, then you should know that the normal pH is 7.6 to 7.64. Okay, so let us quickly revise the aspects of the normal Lights criteria that I've discussed with you. If they ask you that what is the normal pH of the pleural fluid, it is about 7.60 to 7.64. Where does the pleural fluid come from? It comes from the parietal pleura. In case you get a question where the pH of the pleural fluid is less than 7.2, it is definitely an indication for putting an intercostal drainage tube in an individual. Another indication for putting in an intercostal drainage tube that I've discussed with you is empyema lung. Pleural fluid protein is about 2 grams would be increased in an exudate. Normally the white blood cells can be present, but it would be mononuclear cells, not neutrophils. If neutrophils are present in large amount, it's a purulent fluid, it's obviously a exudate. Glucose content is similar to that of plasma. Remember, glucose is not included in the Lights criteria. If the pleural fluid protein or serum protein is more than 0.5, the ratio, I mean, pleural fluid LDH more than 0.6, and then obviously the values of pleural fluid LDH more than 2/3 the upper reference limit of the serum values, then these are obviously gonna be helpful in diagnosis, though he mentions that these criteria misidentify 25% of the transudits. Ideally, all of them should be present, but even if one of them is present, it is sufficient for you to consider it as an exudate till proved otherwise, I would say. Also remember the fact that when would you be putting in a chest tube in an individual, then though I have mentioned this at scattered aspects, I would like you to mention that you are going to put a intercostal drainage tube in the following situations. One is a loculated pleural effusion, or I can just use the word empyema, acidic pH, low sugar, positive gram stain, and presence of gross pus. In fact, I'll say point number 1, point number 4, and point number 5, they basically mean the same only. They're talking about an infection. So only thing that you need to put an effort is to remember the acidic pH and the low sugar values in a patient. I mean, these are indications where you will consider inserting a chest tube in an individual. Now, once you have remembered these aspects, then we'll just quickly practice regarding the characteristics of important exudative pleural effusions. Though I've explained them to you, I especially want to highlight regarding malignancy. When it comes to malignancy, the fluid appearance will usually be turbid to bloody. Bloody, as I've mentioned, could also be TB and mesothelioma. The cell counts will be obviously in excess of 1000. It could be 100,000 cells, mainly even neutrophils present. Even red blood cells could be present there. And the important thing to be remembered is that the glucose values would usually be less than 60 in most of the MCQs that are given to you. Then eosinophilic components may or may not be discussed, but remember, for malignancy, one of the important things to be remembered is blood could be present. He could describe neutrophils, he could describe eosinophils, and low sugar. When it comes to empyema, well, the description will say it on turbid to purulent fluid which has been removed, which is having 100,000 neutrophils present, polymorphonuclear cells present. That's always a cause of concern. When it comes to rheumatoid pleural effusion, it could be turbid to greenish yellow, and one of the highlights of this condition will again be a low value of sugar, and there would be presence of cholesterol crystals, which I've already said before you earlier, but this is just a table that is given in the book, so I thought I'll just share that with you, because they're picking up these slight variations which are given in the table. So whenever you read a table, though I've given you a summary for it, try to analyze the data from the table. When it comes to esophageal rupture, which is pleural effusion associated with Boerhaave syndrome in an individual, the fluid will be reddish brown in color and will be usually having a low sugar with a high amylase level. High amylase levels are found in pancreatitis also, but usually we will find that the sugar values will usually be normal and the appearance of the fluid will be turbid to serous sanguineous. Clinical history will obviously help, no, because Boerhaave syndrome will present with chest pain, pancreatitis will present with epigastric pain and abdominal pain. So clinical history will obviously help. But I am saying that if they do not give you clinical history and high amylase levels are the only ones given, then look at the sugar values, and if you find the sugar values to be normal, think in terms of pancreatitis, and if the sugar is given to be lower side, then think in terms of esophageal rupture in a patient. Color again is very non-specific criteria. So though I have discussed most of the aspects of this table with you already, I just thought I'll show you this table because lots of time we get so overwhelmed by the kind of information given with 7-8 categories. But if you just spend about 10-15 minutes on the table, it definitely gives you edge over your rivals. Now, looking at the gross appearance of the pleural fluid, you can obviously notice a hemorrhagic effusion versus a chylous pleural effusion. This would definitely be chylothorax, and this could occur secondary to trauma to the thoracic duct in the individual. And transudate in heart failure would be just like presence of, I would say, water. The milky white fluid which is present in chylothorax, that would make it very clear, because there would be high content of triglycerides which would be present. The reason for this could be damage to the thoracic duct by the worms, like for example filariasis. These are two images which you know anyway from surgery. You can see a chest tube put in the patient with the extensive amount of pus coming out of the pleural space, and obviously the thoracocentesis procedure is obviously the prerequisite before you put in a chest tube in a patient. And when you put in a chest tube, it's by default put in the fifth intercostal space in the mid-axillary line in the triangle of safety. And most of the time when you put in a chest tube, this will cause a definitive improvement in the condition of this particular patient. So these are inputs from my side on this particular topic. Thank you.